Let me just do a little bit of housekeeping before we start, having to do with this. So first of all, welcome all of you. Delighted to have a robust audience in the evening this way. We're all very keenly interested in the topic of COVID-19 and how otolaryngologists and how an academic otolaryngology department adopts to it. You know, we're all getting a tsunami of communications from all sorts of different sources. You know, the CDC and even our institutional guidelines change every day. And again, I'll ask that everyone would please mute their, we're getting a bit of background noise from some. Thank you. So our goal really is to focus principally on otolaryngology related issues. For our non-Stanford viewers, most of the information we're targeting is rather generalized and would be relevant to you as well. But of necessity, some of the information may be inside baseball relating to Stanford. Apologies that the amount of information is quite large and we easily could go past an hour. Now, with regard to the Zoom technology, you know, we're trying to keep all microphones muted except for the speakers. We have a large number of participants and, you know, it's very easy to have barking dogs and, you know, ringing phones in the background. We do have a chat function and we'd like to use that for questions and for comments. So please, anytime during the meeting, put up your questions and comments. Probably at the end of the presentations, we will look through that list and Ed Damrose or I as co-host will repeat the question. And your comments, of course, are visible to all. So if you have a different—
Hey, Rob.
Yes. Yeah. Someone have a comment? Yeah, okay. So please do share your comments out there, and each individual presenter should have their PowerPoints open on their computers and be ready to share their screens. So with that, it's a pleasure to introduce many of our friends, Lloyd Minor, a fellow otolaryngologist, who has been our leader in terms of response to COVID and has been tireless day and night working to do the very best we can for our patients and our healthcare community. So with that, I'll pass it over to our friend Lloyd Minor.
Well, thanks very much, Rob. And thank you to all of you for the great work that you're doing every day in taking care of patients. Rob, I'll try not to be a barking dog. I really just appreciate the opportunity to speak a few minutes and tell you how much we value the great work that you're doing and the care you're providing to patients under extraordinarily challenging conditions. And Rob, also to thank you for your leadership. And you know, we started about a week ago convening, well, actually Monday of this week, convening every morning 7 a.m. meetings of all the chairs, and we go over updates from the day before and also discuss issues and topics. And as you would expect, Rob has been a real leader in those discussions and represents the department really well. So, you know, one of the things I think that makes this time so difficult is that there's so much uncertainty. I mean, you know, how long are we going to have to, you know, essentially stay in place? Although those of us involved in healthcare are still coming in, and you know, are we going to be able to bend the curve on the incidence of the virus? And I know that'll be talked about tonight. And it's just too early to know these questions. That being said, I think there are a number of things we can be thankful for. One is that thanks to, again, our great faculty, we were one of the first institutions in the country to have a screening test, an FDA-approved RT-PCR. We've tested over 2,000 patients now with that test. It's being used every day. We're still a reference lab for many other health systems in the Bay Area, although they are starting to get their own tests approved, and Quest and LabCorp now offer tests. But that really has helped us to diagnose cases much earlier and make sure that they're getting appropriate care and also evaluate patients with symptoms. Also, we immediately, when we saw that we were going to have issues with this virus and that it was very much in our community, we immediately stood up occupational health. And we're now seeing about 150 people in occupational health each day. We opened what had been the surge area for the ED on the first floor of 300P. We closed that when we moved to the new ED in November, but we reopened it on Monday of this week. You don't need an appointment if you're having symptoms. You simply go. The weekday hours are 7 a.m. to 7 p.m. Still working out weekend hours, but as soon as those are worked out, we'll let you know. But first thing we wanted to make sure is that we provide care for our people whenever you have a question, whenever you have a concern about symptoms. So occupational health is up and running. And of course, people are being tested through occupational health as well. I think there are a lot of questions that I know will come up tonight. I'm sorry I can't stay on the call, but I have to jump on another university-related call at 6:15. There are a lot of questions that are going to come up tonight that I know we won't be able to answer to complete satisfaction because we don't know the answers to complete satisfaction. But I do want to pledge that we want to establish and continue to have a transparent line of communications through the chairs and then from the chairs to the faculty. We also very much want your input into the decisions that are made, into the considerations that are being given to very important issues like the allocation of PPE. And I know Rob will have an update on that. We convened a task force this morning that Rob is on. And Rob, I think you selected another faculty member from otolaryngology, head and neck surgery. And they will have a recommendation tomorrow morning at our 7 a.m. meeting. So we're committed to, when there are concerns that arise, to addressing them quickly, promptly, and in a very transparent and inclusive way. I think it's through that transparency and participation of as many people as possible that I hope that we're able to build your trust, that we're here for you. We affirm our mission of providing outstanding patient care, even in the face of a lot of challenges, but we for sure want to be here for you as healthcare providers, faculty members, staff, nurses, everyone that makes Stanford Medicine such an amazing place. So let me just close by thanking you again for everything you're doing, by thanking Rob for his leadership. And I've got a few minutes here. Rob, if there are questions, if that doesn't interfere with your plans for the town hall, I'd be happy to stay on for a few minutes here and try to answer any questions you may have.
No, that's wonderful, Lloyd. If you hit the chat button, it will open up a window on the right-hand side, and you can go ahead and put in your question at the end that you would have for Lloyd. And if you just go ahead and post that, and it says everyone surrounded in blue, and you can put it to everyone so that we can all see.
Rob, I think I'm having trouble seeing the chat, so you may need to read. Oh, no, here it is. Never mind. Sorry, Rob.
The button on the bottom.
I got it. Yep. Thank you.
Well, it worked for me. So you know what,
Yeah,
Lloyd?
it's
There
on.
you go. First question, thank you for inviting UCSD. You are very welcome, as are the other California schools. We're delighted you're here. And if there are no content questions, I'm going to go ahead and begin the planned program, although we hope this will be interactive as well.
Thanks a lot, Rob.
Thank you very much, Lloyd. Take care. Yeah. I'm going to talk for about 15 minutes, distilling a number of the key points around the COVID issues and as they relate to otolaryngology head and neck surgery. And then we're going to have a number of the leaders in Stanford otolaryngology, notably Ed Damrose, who's the chief of staff for our adult hospital and has been very much involved in the COVID response. So I'm going to dig right into it now. So first of all, the novel coronavirus, as most of you know, is also known as COVID-19 or SARS-CoV-2. It is part of a family of coronaviruses that have given severe acute respiratory syndrome. It's a zoonotic. It comes from bats from a particular animal market in Wuhan, China. It is a first cousin to SARS, which was around in 2003, and also to MERS, which is the Middle Eastern variant. Both of these, interestingly enough, were controlled by public health means. Now, the current coronavirus 19 is more infective than SARS or MERS. It's easier to catch, but it is less lethal than the other two. Now, the epidemiology, as you know, is indeed a global pandemic. Worldwide, there are almost 250,000 patients known to be infected and about 9,800 deaths as of today. In the US, we have 13,000 infections, which is 40% up in the last 24 hours, including 176 deaths. The death rate in Italy today has actually crossed more than was in China. It's now 3,400, which is a couple more than we saw in China. Now, when we give these numbers of 13,000 in the US, most of you know there's a testing bias. We've been very limited in testing. Therefore, we have the tip of a very big iceberg or pyramid. And in fact, those 13,000 are probably multiplied many times over for the actual numbers in the population at large. Now, the epidemiologists tell us that the doubling rate currently is about 5 to 7 times, is about 5 to 7 days for doubling. And that modeling is pretty sober. The best estimates we have is that we're going to peak, if nothing changes, sometime in the latter part of this month or in early April. If you want to monitor this, I would recommend the Johns Hopkins COVID map, which is very good. It's easy if you just Google Johns Hopkins COVID map, and also the CDC for the US. Now, how does this disease present itself? Most COVID-19 are flu-like symptoms, but some people have no symptoms at all, especially young people. Most serious illness and deaths have been primarily in elderly and in those who are chronically ill. And the highest rate, of course, is in those who are both elderly and chronically ill. Now, it shows up often with fever and cough, and it often comes on insidiously, kind of a scratchy throat and dry cough that builds over 3, 4, 5 days. It's very different than influenza. Influenza, you get suddenly sick and feel miserable and have symptoms right away. COVID kind of slopes up, and it often plays out over 2 to 3 weeks in its course. Shortness of breath heralds serious pulmonary problems and certainly should be evaluated. It is an interstitial pneumonia. The cough is not productive. There's not a lot of mucus production. It seems that the slice of people that get seriously ill, it is principally driven by a hyperimmune response to the virus, which leads to an adult respiratory distress syndrome. As our rhinologist, sorry, Zara Patel tells us that there is an incidence of post-disease anosmia, which is just becoming recognized. Now, deaths have been mostly in elderly people with cardiac problems, hypertension, pulmonary disease, particularly long-term smoking, renal failure, and diabetes. It is much higher, greater than age 60, and as much as 20% death rate in Wuhan population in the 80s. Now, what is the actual death rate? Most people think it's 1%, maybe a little bit less than 1%, but that is still many times more than the standard seasonal flu. The good news that's very reassuring, and as a new grandparent, I'm very reassured by it, is there have been no deaths in children under the age of 10 reported so far. Now, how is it transmitted? So it is possible to transmit before there are symptoms, and that's beginning to more and more be studied, but it's probably not the principal mover. The principal mover is intimate contact, kissing on the cheeks or touching closely, or contact with a coughing patient particularly. Now, some young people particularly have COVID with minimal symptoms, but they're still very capable of spreading the disease. Now, it is probably, and this is becoming clear, more droplets than aerosol. And this becomes important because a regular surgical mask will catch droplets, but an aerosol, and famously measles as an example, will go around a mask, but this presumably is more caught by one. Now, the virus can remain infectious in the atmosphere. So if you've been in a confined space coughing, there can be suspended and active virus particles for some hours. It can also live on surfaces, particularly impermeable surfaces like metals and plastics. Less concern, you know, when that FedEx guy comes with your food delivery or whatnot, you know, paper and cardboard are less of a concern, certainly, but still one would consider it. Now, testing. testing is very important for us in otolaryngology, but it's still very limited. So the PCR kits that you hear on the news are becoming much more available, but they're no use unless you have the ability to do the RNA extraction, and if you have the proper swabs for the nasopharynx and the viral transport media. All of those are currently limited and become the rate limiting step. Now, sometimes these assets are in your laboratories at your institution. So we've actually tried to scrub across Stanford research, and we've found quite a bit of material, kits for extracting RNA, for example, that have been helpful. Now, the way testing is being done is not to go in a clinic and exam room and contaminate it and everyone in the waiting room. We have screening outside all of our otolaryngology clinics. Patients who come with a cough or come with a fever are not allowed into the clinic. We actually will refer them to a video visit and phone call with a pathway that's been set up. And there's kind of a NASCAR style pit stop where they drive up in their car and someone in full gown and regalia will do the swab at that time. So it's a drive-through model. At the peak, we were running 20% positive in our testing at Stanford. That has declined down to about 4 or 5%. What that means is, because we're not testing asymptomatic people, is that a large number of people coming to us with cough and fever are actually coming back negative. So there are other respiratory diseases out there. Now, Ed Damrose, as our chief of staff, is going to give you a lot more detail about the hospital, but a few points that are relevant. One is that we have a no visitor policy now, none. Minimal number of clinicians should enter the room when we need to see a hospitalized patient. And we're concerned about blood banking because donors can't come in to give the blood. Now, we are a vulnerable specialty in otolaryngology, very much so, and perhaps uniquely so, but we are not alone. Also, dentistry, as you can imagine, pulmonary medicine, anesthesia. Every time they intubate, they're exposed to respiratory secretions. The frontline screeners in our emergency room, and also those who are caring for hospitalized patients. Now, I've got to tell you, a member of our clinical team fell ill with COVID and was very sick. And actually, that person, thank God, made it through. It was kind of touch and go for a while. That person now is fully recovered and is back home. We are all delighted. Now, we have heard by a number of our faculty who have communicated with China, with Italy and Iran, that in fact, these are all secondhand sources, but we are the #1 specialty for illness and death. And we've been reported that there have been series of deaths in China, as well as in Italy, and as well as in Iran. So I think we need to be especially careful in our field. So the virus is respiratory. There's a high load in the nose and nasopharynx and in the trachea. In terms of the bloodstream, let's say you're going to have to do a neck dissection. It isn't clear that there is a viremia to any degree, and it's not known whether non-respiratory aerodigestive tract procedures carry a significantly higher risk, other than the fact you have an intubated patient breathing out around the tube into the room, for example. But respiratory tract surgery produces droplets and aerosols both. And as you'll hear from Zara, endonasal surgery, especially functional sinus surgery, is perhaps at the very highest risk, because when you use debriders and drills and sprays, it produces a big plume of potentially infectious particles. Now, the vulnerable ages matter not only for patients, but also for healthcare providers. So members of the healthcare team, all of it, not just the doctors, are at risk over the age of 60, particularly. Now, we have 4 surgeons over the age of 65 at Stanford, and I spoke with each one of them and said, you can make your choice, it's up to you, but if you want to withdraw from direct patient care with the exception of video visits and phone calls, that's your choice. And all 4, including me, I'm 66, agreed to do that. And it actually makes sense because we have a sufficient workforce in every single of the otolaryngology divisions to be able to carry on very well. And of course, our volumes are notably diminished, both in the clinic and the operating room, which helps. Now, in terms of our philosophy of clinical care, our department clinics and operating rooms need to stay open to serve those we need, both the affected current epidemic patients, but also the seriously ill amongst those patients that we normally care for in the population. So what are we doing for surgeries? So first of all, urgent surgeries only. So we've shut down the vast majority of our surgery. Now, you might say, what's the definition of urgent? That's an important point. Well, I've asked every division chief to work with their faculty to come up with a list of what they consider urgent in head and neck and rhinology and otology, those kinds of things. Now, if an individual faculty member wants to put on an operative case, they need to run it by their division chief. If it's obvious and needs to be done, there's no problem. If there's any question about it, they bring it to me. And sometimes it goes forward and sometimes it does not. It just depends. But I want you, when you think about surgery and you are committing your patient to surgery, it's not just about your well-being of the patients. If you're exposing the entire operation ecosystem, pre, post-op, everybody in the OR, and I think that's important to know. So we're trying to reduce in surgery the number of people exposed, and we're trying to reduce the number of cases to preserve our limited supply of protective gear. So while education is care to our mission in all of these, our academic medical centers, protection of everyone's health is our highest priority at the present time, and it trumps education for the time being. So surgery requiring a single surgeon, it's going to be done by the attending surgeon alone. If we have multiple surgical needs to expedite it, we're recommending the most advanced resident and/or fellow assist the attending surgeon, and that we ask the attending surgeon, if possible, to stay in the room the whole time participating to expedite it getting done efficiently and quickly. We're also asking that there be no students, no visitors. We don't want the junior residents standing around the table. We just think that's an unnecessary exposure. We are encouraging everyone to tape. It's not tapes, is it? It's digital capture, the video, endoscopic and microsurgical procedures, ideally with a voice mic so you can narrate that will be shared. Maybe spend some time with your residents and fellows later going over what was done and why so that we have education continuing. Now, what about all these cases we're canceling? So we have not started rescheduling anything yet. We just don't know the timeline of this, and it's going to be a nightmare for all of us. But looking forward, as we're starting to do towards the resumption and the broadening of urgent into things less urgent and more elective, one possibility is that we'll be doing routine pre-op testing of patients. Now, we don't have the bandwidth to do that, but we will hopefully in the coming weeks. And if we test everyone, then those that are COVID positive, we'll let them wait for 3 or 4 weeks till they clear it, and then we'll do their surgery. Those that are negative, well, it's not 100% guarantee. The tiny fraction will be pre-symptomatic. Maybe we can go forward without so much concern. Now, telemedicine, I should say that, so telemedicine, I'm sorry. Let me talk for a minute about our clinic. Let me talk one thing, excuse me, in OR I would like to say, we are having workforce problems. I bet all of you are in your respective places. And the reason for that, amongst other things, is the fact that schools are closing and some people don't have backup childcare. Also, in the past, when we've had labor needs, we've called travelers from other cities. But those cities now really need their people at home. And also the ability to travel across the country is very limited. And so it's going to be a challenge to keep our services up as a surge occurs. In terms of our outpatient clinic, and you'll hear from Jennifer Lee, who's our clinic chief, about this, urgent patients only. But please know, we're not canceling our clinics. We're not shutting down our clinics. Our clinics remain open. Visits are probably down 80 or 90% in most subspecialties, maybe a bit more, a bit less than that in head and neck, for example. On our assigned clinic days, the individual faculty surgeon may have only 2 or 3 patients. You see them by all means, but you keep your phone available. If someone needs to be seen that day, you are on call for your clinic days to come in and see urgent patients if need be. The reduced numbers of patients help conserve scarce PPE, the protective gear as well. Now, we do have a screening in place outside of our waiting room. That means that before you ever come in the building, someone is going to screen you for fever and things like that. Now, telemedicine. Most of us in otolaryngology, because we're so exam intensive, have not been doing a lot of telemedicine. But video visits via our electronic medical record system at Stanford, it's EPIC, are preferred. And we have webinars going on, and I'd like all the Stanford folks, if you haven't taken one or done the online training, it takes time actually to get used to doing video visits. Our children's hospital, Lucille Packard, as Alan Chang, who is our chief there, is going to talk about, does have video visits from home on EPIC. Stanford Hospital doesn't, but under these emergency circumstances, they are allowing us to do visits on Zoom and WebEx, and later record the visit in a note in Epic. Each department is appointing a video champion, and we'll be doing that. Now, some general considerations about protective gear. I'll call it PPE. As a general rule, it is reassuring that PPE is quite effective if worn correctly and used correctly in preventing infection in caregivers. If you haven't watched a training video on how to put on PPE and take it off, it's not entirely intuitive. Don't be embarrassed to watch it. It's not a bad idea. We showed it at our March faculty meeting, actually, and we all watched it. Gloves and hand washing are primary, at least 20 seconds, they say. Probably better than alcohol gels because it's not been proven, although alcohol gels and other coronaviruses are effective. Now, there are two kinds of N95 masks. Some of you may have gone to Home Depot or ordered on Amazon, and they may be the industrial masks, which preferably work on particles rather than moist biologicals. Now, in a shortage, even in a healthcare setting, those type of N95 masks are still valuable. But you know, in high-risk cases, you don't want to be using industrial one. You want to use one of the certified medical ones. Now, because we all are stressed out on not having enough N95 masks, we need to reuse them. So ideally, unless they've become grossly contaminated, use it all day long for patients. If you have, when doing the exam, if it's a coughing patient and you're worried about it, if you've got a plastic face screen to preserve the mask and also keep anything off your face or eyes, that's a great idea. We don't have enough face screens here at Stanford, and because of that, one of the tricks people are doing is putting a surgical mask, a regular mask, over the N95 when you're doing the exam, because if anyone coughs or sputters, you then take off the outer mask. That's a bit controversial, although the CDC does recommend that as a way of saving our higher level materials. Now, I'll mention that theft has been an issue of these things. So you want to keep your N95 masks and other PPE locked up in a cabinet or a locked area. And infected individuals are going to keep shedding for a few weeks. So most places recommend 2 negative nasal swabs at the end of the period before they're released from it. We are fortunate now that many of our PPE supplies at Stanford are adequate at present levels of use. But present levels of use is relatively low compared with what it might be as things go. In certain categories, we don't have sufficient things, as I mentioned, for example, face screens. Now, PPE in clinic, as you'll hear from Jennifer, universal precautions. I highly recommend that for every patient, you wear a regular surgical mask. Everyone you're seeing face to face. When you do the exam, certainly. If you have a coughing patient or sneezing patient, they should wear a mask that's only removed for the time you need to do your examination. We are strictly limiting endoscopy. Both rigid and flexible endoscopy are a high-risk procedure for us. So we're recommending, even in clinic, eye protection together with an N95 mask, together with a gown, actually, for endoscopy particularly. In surgery, and Peter Wong, our vice chair, and also who heads our clinical programs, Peter is going to talk a little bit more about this, but if you're doing airway surgery in someone who's known positive, you need to know there's a higher level thing. There's capper and papper, which are these full head things with a machine behind you and all that. Those are the highest level. They are scarce. They are scarce, but sometimes they're well justified. Now, a few more comments on prevention. So when do you come to work? When do you not? So certainly if you have both fever and cough, you should engage your occupational health people and get taken in for testing. If the testing is negative, you come back to work wearing a mask. Our occupational health people right now are saying if you've merely got kind of a cough, and rhinitis, runny nose, is not terribly typical of COVID. And so we're not as worried about that. When in doubt, seek the advice of occupational health for members of your healthcare team. Now, we're all very much involved in social isolation. In our part of the state, all 9 counties in the Bay Area are currently socially isolated. The effectiveness of this here in California is unknown because we're still in that period where it's that 5 or 6 days before the exposures that happened a few days ago. But in a week or two, we should have a better idea about whether this is helping to bend down the growth curve of the epidemic. Now, young people feel less vulnerable, and they have not been isolating enough. And they, this is all herd immunity, folks, so they're passing it around. So the CDC just came out with some rather stern warnings about young people getting serious disease, and I think that's helpful. Now, the message out of China, and you will have to be a bit careful about taking this at its meaning, they put 1 billion people in very strict isolation, and they seem to have no new cases. However, I'm not so sure how real that is. And they're kicking out people from the New York Times, Washington Post, and Wall Street Journal. But if that is true, if that isolation really is effective, that would be an excellent thing. The name of the game for all of us is to minimize the chances that we and our patients and team get infected, and wait until a vaccine comes out or online. Hopefully this thing will undulate a bit and go down in a couple of months, and we can come back more to normal. The world has seen many epidemics in the past. We will get through this. We will pass on from that. Now, the treatment in COVID is really, there's no treatment. It's just supportive if you have a mild or moderate illness. But early intubation, for people who are in failure is important. And the reason that's important is that if you do emergent intubation when someone's crumping, you're much more likely to have problems with not being properly protected. Now, I want to share with you the one really promising emerging drug that's coming out, which is remdesivir from Gilead, which I've had to learn a lot about. It's an investigational nucleotide analog. It's a broad spectrum in its antiviral activity, both in vitro and in vivo in animals, and has been tried in Ebola and MERS and SARS with perhaps some effectiveness. It's a daily IV dose for either 5 or 10 days. Now, there are 3 pathways for a person who's hospitalized to get remdesivir. One is compassionate use, when people are starting to really advance in ARDS, as our patient, our colleague did. And that individual, got remdesivir and turned around. Now, whether that was natural history or whether that was effect of the drug, I don't know, but it made a big difference the day after. So it may well have had an effect. Now, out of Omaha, Nebraska, there is a 50-country study with 50 centers. It's global. Stanford's one of them. Some of your institutions may be as well. And there are 3, it's a phase 3 clinical study. So there's 2 lanes that are important to be familiar with. If you're moderately ill, that is to say you have patchy infiltrates in your lung but don't need oxygen, then it's a 3-way thing that includes a control group that's untreated. If you have more severe disease where your oxygenation is impaired, then it's an open trial where everyone gets it, and we'll see. Hydroxychloroquine, which we know from malaria care and sometimes rheumatologists use it, also seems to have some effectiveness in vitro and in vivo in animals, not really known in humans. Just last couple of things, tracheotomy. Now, tracheotomy may not be that relevant for coronavirus for a couple of reasons. It's an interstitial pneumonia, and there's not a lot of mucus production, so there's a little need for pulmonary toilet, and suctioning. So that would not be an indication. The other thing is prolonged intubation doesn't appear to be necessary. Either the people who get intubated with this in respiratory failure either die, and they do so in a very large fraction, or they recover, but they don't end up in long-term intubation, although that may change. So we've seen. Nilash, one of our residents, is going to present a bit about the global perspective, and I would point you to William Wei's University of Hong Kong 2003 paper on tracheotomy management in the SARS population, which has relevance. And the last medical thing I'll leave you with is about us as airway surgeons. We are a backup in our institutions for care and management of the airway. And if we start having enormous numbers of ICU patients requiring intubation and management, and we've stripped beyond what our critical care and anesthesia people can manage, we are a backup team in that way. Now, if things get really bad here at Stanford, we're going to do a mannequin-based and endotracheal intubation and management course for people like me and otologists. I haven't been intubating in recent years, except for maybe eardrums. So we'll all need to have some, but I don't think we're there yet. I hope not. But I'll leave you, before Ed comes on, with a piece of philosophy. Let's all be careful and vigilant, not only for our own protection, but for the entire clinical teams that we lead. After all, we set an example for our trainees and staff, the behavior that we emulate. We have to keep ourselves healthy to serve the patients that we all care for. Now, before we go to the questions, I'm going to have maybe Ed come on in and do his presentation overviewing Stanford Hospital, and then we'll maybe go through some questions and then move on to a number of our other discipline experts. So thank you.
Thank you very much, Rob. This is Ed Damrose, and hopefully, Rob, are you seeing my screen, the presentation?
Roger Wilco.
Okay, great. And okay, great. So I'm going to just speak to you all tonight a little bit about 7 topics from the hospital perspective: operations, communication of information across the medical enterprise, a little bit about testing, what we've done in ambulatory care, the visitor policy that Rob mentioned, PPE, and then how we're going to approach expanding our ICU capacity. Just by way of organization, and I apologize to our guests, this is going to be Stanford-centric, so just please take this with a grain of salt and a little bit of a high-level view of what we've done here. But essentially, we've organized the governance around standardization of policies relating to COVID into something called COST. It's our Clinical Operations Steering Team. This is essentially the governing body that is authorizing hospital policies that cut across all of our aspects of our clinical practice, from nursing to the operating rooms to outpatient to inpatient. So everything that we decide as a group, and this is comprised of experts from infectious disease, from supply chain, from the hospital administration, and the chief medical officers of both the adult and the children's hospital. This is run through COST, and this is a group that meets every day and promulgates new policies out to the medical staff. So that's how this is being operationalized. And there are a number of subgroups that are actually reporting to COST, and I won't belabor the details here, but just to say that this is a tremendous number of individuals and experts and specialists, including the service chairs and their designees, who are contributing to this. Now, I will say that, as I suspect most of your hospitals are, we are operating under our emergency management plan, which empowers us to do certain things in a time of crisis. We are able to expedite recruitment of medical providers to Stanford without following the standard and lengthy credentialing process, which can take several months in most cases. And this is allowing us to recruit primary care providers, internists, and other doctors to do the medical screening examinations that we need. So essentially, operating under the emergency management plan is enabling us to expedite the credentialing process. Now, we are trying daily to be as open about communications as we possibly can and searching for novel venues to do this. We send out essentially a daily email from the chief medical officer and the chief of staff office with updates regarding policies and important information. We send out videos via email as well from our chief wellness officer and others, instructing our colleagues and our staff on new happenings regarding COVID. We have established a website on our main web page, which is a repository of policies and helpful information around COVID. Suffice it to say, there's no way to communicate enough or as frequently about this, because the data is changing almost hourly as our policies. But we're doing what we can, and there's a variety of ways as we can to maintain the communication. Some novel things that we've tried to do is to roll out instructional videos that can be uploaded to your iPhone by scanning a barcode. So this is on the left-hand side here. You see videos regarding the donning and the doffing of PPE, and then we have other videos as well, for example, of how to use a capper or a PAPR system. In terms of testing here at Stanford, as Rob mentioned, we began our own in-house testing on March 2nd. This was developed in our own clinical labs using a PCR-type-based model. It was initially, it was subsequently approved by the FDA, and we are now able to run around 200 to 300 tests a day. We're not only testing internally our own patients, but we are providing testing to a number of hospitals in the Bay Area, area, including UCSF. We can do about 200 to 300 tests a day. I want to emphasize, though, that testing is not the same as collecting. We can collect many, many specimens, but because of limitations in reagents and the testing supplies needed to run the tests, as Rob stated, we are limited in how many results we can produce, and the wait time for a result is approximately 24 to 48 hours. In some cases, it's been a little bit longer. Right now, we've restricted the ordering of these tests to the inpatient side, emergency department providers, and occupational health. And this is because we have decided to prioritize who should be tested in which order. The sickest inpatients and the immunocompromised inpatients have priority, followed by our providers, and then it goes from there. We also have set up, as many of you on the call have, drive-through testing. So you stay in your car, show up to an external site, you can be swabbed right through the window of your car, the test is collected, and then you can go home. Now we do this, this is being run through primary care. We also have sites here at Stanford on occupational health in the emergency department. As Rob mentioned, our COVID screening, we're getting around, for all of the screening that we do, about 4% positive. And just to give you some numbers, 2 days ago we had approximately 35 patients in the adult hospital as persons under investigation. Of those 35, 12 were positive. Today we have 51 patients under investigation and 12 are positive. So the numbers seem to be remaining fairly stable. What we have done for our providers here, and as again Rob has mentioned, is to set up an occupational health pathway. If providers think they may be positive or have been exposed or may be sick, they can call into our occupational health evaluation center. If it's deemed that they need to be tested, they can come into our occupational health center Monday through Friday. This is now going to be expanded to weekends, I believe as early as this weekend. But for other times and availability, it's through the emergency department. And I suspect many of you on the call who are not with Stanford are going to be doing something similar as well at your own institutions. This has been somewhat of a challenge to try to flex up the staffing in occupational health and to return calls in a timely fashion, but it's getting better every day. So also as an institution, on March 13th, we decided to cancel all elective surgery. So this was in an effort to do several things, principally and primarily to contain any exposure to healthcare providers and patients as much as we can to the COVID virus, and also to decrease the use of PPE, which is restricted and of major importance in this pandemic. This is also allowing us to plan ahead and decant somewhat the inpatient census so that we can provide availability for the surge of patients we expect to admit. And then down the road also, we think that this will impact readmissions as well. So again, this is to increase capacity, decrease exposure, and decrease our use of PPE. Now we have a triage system that we've set up to define what is meant by an emergent condition, urgent, and elective. This three-tiered system here, actually you'll see play out in a number of the decisions we've made as an institution. Emergencies go, but urgent cases, if they are deemed to be necessary within 30 days, are generally discussed at the level of the division chief, and then, if need be, clarified by the chair. These decisions about the urgencies of surgery we felt should be really left to the discretion of the surgeon. This is not something that we want to be seeking permission from anesthesiology or nursing. We are being very careful and judicious, though, about the cases that we elect to pursue. If there actually is a conflict, then it's resolved at the level of the chair. Today, as Rob alluded to, we have a subcommittee that met to discuss how we're going to implement our policies around PPE. Part of the implementation has been to also decide how we're going to triage cases in our operating rooms. In cases where it's an emergency, we're asking everybody to adopt full PPE. That's an N95 mask, gown, gloves, and face shield. For urgent cases, if it's a high risk, meaning that the patient is thought to be high risk for COVID positivity, If we can delay, we will. If we can't, and we can get a COVID test within 48 hours, we'll do that. If the patient is still positive, we do want to have confirmation from the chief medical officer, the anesthesia chair, and the surgical chair before proceeding in this high-risk patient electively. For patients that it's a low-risk procedure, meaning low risk of COVID positivity, and of course, if it's negative, we will proceed. But this is a little bit of how we're going to be approaching this here at Stanford. Part of our core principles has been to recognize that all intubation and extensive bag mask ventilation is going to be considered a high-risk type of procedure. So that's just how we're conceptualizing this. As you'll hear from Dr. Lee momentarily, we have decanted our outpatient clinics and are seeing emergent cases, or urgent cases rather. However, we are ramping up our ability to do clinic visits via telehealth and telemedicine. To give you an idea of how fast this is going, we saw about 1,000 televisits in February, in the entire month of February. On March 16th, we saw 1,001 in a single day. So we're very rapidly transitioning now from in-person visits to telemedicine type visits. I've been informed by our chief information officer that the Office of Civil Rights here in California is relaxing the interpretation of HIPAA to allow these types of visits to proceed. Our first line of visit is to use our Epic-based platform here, which is fully functional, but not all laptops and other mechanisms are available to our providers yet to do this. In lieu of Epic, we are allowing people to conduct a telehealth visit using Zoom or WebEx, and we're even allowing FaceTime, Google Hangout, and Facebook Messenger where allowed. We are especially thinking of this type of interaction for patients that are hospitalized where we don't necessarily want to go into the room and expose ourselves, but just to check on the patient or ask questions. So all of these are currently allowed. We are working through the billing issues around the use of these latter technologies. I wanted to also tell you about some changes that have happened here as well. And again, for those that are outside the Stanford system, you'll probably be looking at similar things. Patients that require radiologic examinations, we are trying to triage to emergent and urgent exams. This applies principally to outpatient exams only, not inpatient procedures. We're asking that exams that are basically screening exams not be scheduled and not be done. And here is a list of the screening examinations we felt that are not appropriate for imaging right now. As you can imagine, these make a lot of sense. Coronary artery calcium scoring on CT, some screening mammography, and some other things as well. So again, if we're using this triage system of emergent, urgent, and so forth to kind of stratify how we will approach this, this is going to be likely subject to change here at our institution as we hear input from other service lines that are going to be impacted by this rationing of the radiologic evaluations, particularly ortho. But again, for all of our providers here, just understand that for exams ordered on March 16th or after, screening exams will be scheduled for later on in the year, and then all others are going to be moved down to next appointments. As Rob indicated, we have instituted a strict visitor policy here. The bottom line is that we don't want visitors coming in. They may be spreading the virus, may be exposed, or may be tapping into our supplies of PPE. However, we are making exceptions for patients that are dying. If patients are COVID positive and they are dying, we are allowing some exceptions for individuals to go into the room and be with a person who is, on a case-by-case basis. And so these kinds of things are being escalated. If a person is symptomatic and sick, they are not going to be allowed here into the hospital under any circumstances. Now, this is this decision to make this policy was carried out in concert with a recognition that at our baseline there are approximately 75 individual pathways into the medical center, doorways, hallways, underground passages, etc. And we've decided to limit these as much as possible. So these have been blocked off, and around our medical center you will now see signs in front of entrances and down corridors recommending that these avenues not be used. We have increased security at the main choke points entering to the building, where we can actually screen people and inquire if they are having symptoms or not. And again, symptomatic people will not be allowed into the building. At our discussion of one of our meetings today, the decision around how to handle scrubs was brought up, and it's very likely by tomorrow an announcement will come out that scrubs cannot be worn outside of this medical center. So to and from work, wearing of scrubs will have to stop. We'll need to change inside the building and then change into our civilian attire before we leave. And this is again an issue in an effort to mitigate the spread of virus or other contaminants in or outside of the medical center. So stand by for those of us that work at Stanford for that. I'll say a few things about PPE. This is an example across the top of the slide of how we look at the different items in our supply chain. We want to know not only what it is and where it's located. In our case, is it solely here at Stanford? Is it across our other hospitals? But how many days on hand that we have, whether or not there are substitute items available, what is the market availability? Items that are considered high priority with very little reserve or days on hand are given a risk rating from low to medium high. As you can imagine, N95 masks and face shields are considered a high risk device right now. And we have recommendations around conservation and guarded usage, and we want to calculate burn rates, meaning how much of this stuff we use, how good are our replenishment supplies, and then as the infected patient burden increases in our hospital, how will that affect our burn rate? The bottom line is that to conserve PPE, we're going to be making a number of strategical maneuvers. Co-location of patients is already being done. We have a dedicated ward on B1 where all persons under investigation for COVID will go. We've decided to limit visitors, observers, students, trainees into the operating rooms and in the care of the patients in order to conserve PPE. As we mentioned, elective surgery is canceled. We are going to start to allow or develop policies and utilize and allow PPE to be reused. We have recognized that there is probably because most of us are not used to wearing PPE, there are serious risks of contaminating ourselves in the environment with improper donning and doffing. And we have videos showing how to do this, but we're going to have to make a very concerted effort to do this properly. Otherwise, we're going to contaminate ourselves. Interestingly, in this crisis, we're getting many, many calls, inundated with calls, people that want to volunteer and also to donate supplies. I've been getting a number of calls, believe it or not, from China, where they have excess equipment that they want to give to us. And we've set up an actually receiving website through supply chain, COVID-19 supplies. Now, we can't take individual donations, unsealed or open products and supplies from sources we can't verify, but we can take medical grade and verifiable materials. And so we're getting donations for supplies to help us. And this is very interesting how many people are actually coming to our aid and to other hospitals in this time of crisis. I wanted to show you something on this slide here, which has been a model put together through our clinical analytics teams. And it's a busy slide, but I wanted to just show you how we are calculating what might happen over time. This is a model based on a number of things, including the R0 of the virus and the current infection rates that we have seen in other countries and what we are seeing in this country. This line here represents the number of infected patients we think are likely to be coming into Stanford over time. This line here represents the number of ICU beds that we have. At this point in time, we have approximately 83 ICU beds in the hospital, and we think shortly later this month we are going to roughly hit ICU ICU capacity. Over time, this line up here represents the total number of ventilators currently in our hospital, and approximately early on into April, if the trends that we have been seeing and modeling are correct, we expect to hit maximum capacity of our ventilators on or around April 9th. So we can see what is happening on the horizon, and we are taking steps to mitigate this and increase our ICU capacity. This is a schematic outline of our hospitals. We opened our new hospital, which we call 500P, in mid-November. Our old hospital, we term 300P, is shown here. We have about 368 beds total in the new hospital and 203 in the old hospital. This gives us a total of 571 beds throughout. And with our current configuration, we have about 95 ICU beds throughout both facilities. Now, when the new hospital opened, I'm not going to show this, I'll just skip right along, but when the new hospital opened, it was always conceptualized that we would actually start to renovate the old hospital. And the renovation was supposed to start with our D, E, and F pods. Now that this pandemic is upon us, we are calling a halt to this. Now, this is a picture down here for those of us that work at Stanford of how the D pod looks now. Equipment including cardiac monitors, ice machines, station monitors, et cetera, have all been stripped out. What remains is electricity, gas, and wireless. And what we've decided to do is to call a halt to that and start reactivating the D pod to increase room availability. This is going to impact our overall renewal project and push this down the road, as one can see. So we'll be coming back to this when we actually get through this pandemic. We expect that we'll have the D pods open again and ready to go on March 30th. This is, believe it or not, because as you can imagine around the country, so much equipment and supplies in high demand, we're going to be cannibalizing from other areas around the hospital, taking WOWs and EKG machines and beds from other areas to try to bolster up D2. So what about our plan for the ICUs? So we have three levers that we can pull. We can convert our regular ward beds to ICU beds, and this is principally possible in the new building on the L4 level. We can reactivate decommissioned units, as I talked about, the D pods, which we are going to do, and even one of our older ICUs, the E29. Those that don't work at Stanford may not realize this, but prior to November, all of our hospital rooms were semi-private, so at least 2 people, 2 room, and then that converted to private when we opened the new hospital. Now we have the capacity to go back to semi-private in the old hospital. Now there's a couple of things. It's not as easily said as done. We can open up beds, but that's a completely different prospect from being able to staff them with nurses. And also in terms of why we want to do this, this is again not only to kind of co-locate patients, but we also want to minimize the use of PPE. We want to co-locate nurses with similar skill sets into similar areas, medicine to medicine, surgery to surgery, and we also want to minimize splitting of teams across the 2 hospitals. That's geographically a large distance for people to go. And just and I'll be almost done here if you'll just bear with me just 2 more minutes. This is our current allocation of ICU space in the new hospital. We have about 84 ICU beds total. J4 over here, which is used as a regular patient ward, can be converted to ICU beds. In our old hospital, which is shown here, D2 and E2 is where we were doing the retrofit. D2 and D1. E2 is an old ICU, which can also be retrofitted. B1 is currently serving as our holding area for all PUIs. This is a negative pressure area and can hold about 17 people. So how this is going to play out and what the cost group has decided to do is we're going to go ahead and recommission D2. We're going to recommission D1. We're going to convert L4 over to ICU beds. And what we hope that this will allow allow us over, and we can do this in a very stepwise fashion, is if we can do this, we'll increase our capacity from about 83 to 84 beds and 10 negative pressure ICUs to 135 ICU beds. If we convert to semi-private rooms, we'll gain 159. If we recommission E29, we can ramp up to 174 and gain 46 negative pressure ICUs. So the bottom line is that there is a stepwise plan in place for us to increase ICU capacity to chase this pandemic as we need to. Part of this emergency plan will result in us having to utilize the current recovery room space in the new hospital and in the old hospital, including the Lane surgical area where the head and neck service line currently exists, and use these recovery rooms for patients as well. So this is basically our plan, just in a high-level view, to deal with some of the issues that are facing Stanford Hospital in its entirety. And with that, I'm going to end my presentation. So thank you.
I want to thank you very much, Ed. You can see how we're very fortunate in otolaryngology to have such a capable chief of staff and how informed he is about all the different things going on. It's an example of how this institution and each one of our institutions, of course, have their own unique attributes in that way and are facing similar challenges. So I'm going to ask all the additional speakers, because we're already at an hour, time goes fast, to try to get the high points of what's important there in about 5 minutes if we could, so that we leave a little time at the end for some questions as well. So introducing Jennifer Lee. Jen is our clinic chief on the adult side at Stanford Healthcare. Jennifer, do you have any slides?
Yes, let me just share my screen. Oh, it says somebody else is sharing. Okay, got it. All right, good evening. I have one slide. I will try to make this as quickly as possible. I just want to emphasize what we're doing at Stanford that's hopefully helping out, and some updates on video visits. So what we're doing is, in the clinic operations, is shifting the screening as much as possible prior to the actual visit. So we have centralized scheduling that are screening for symptoms actively. If they're positive, then they are directly warm transferred to a live nurse who evaluates them. And as previously mentioned, they get seen at Express Care through video visits and drive-through testing. In addition, we have online reminders, and we're scheduled sweeping on a daily basis as well as weekly basis for patients that are scheduled the following day and up to a 1-week turnaround. We have entryway screeners as well as front desk screeners that have been screening for symptoms. And if they're active, we like to emphasize that we've been rescheduling, not just canceling, so that they can be seen, so their needs can still be addressed and met. But at the moment, they are turned to Express Care for video visits and for them to get their acute needs met as well. During the clinic visits as well, we've instituted universal precautions a little bit earlier than some of the other areas in terms of masks and gowns and protective equipment. We use surgical masks, and when there's concern for respiratory issues, then we use N95 masks. Initially, there was a significant shortage. There continues to be shortage, but we have been able to manage and use N95 masks by kind of conserving as much as possible throughout the day. As previously mentioned, we're going into urgent visits, and I'd like to spend a little bit of time about video visits. So Stanford SHC has instituted video visits. They have requested that we use the EPIC ones, preferably. And they've actually been pretty good at turning around and getting us laptops and equipment. I can tell you that I submitted a request yesterday, and tomorrow I will be picking up my SHC approved laptop. It is nice to use it through EPIC because it allows us to take screenshots. Billing documentation is all built into the EPIC system. So it is encouraged that if possible for you to use SHC equipment, because it just streamlines things to make things easier for us to do. And in terms of billing, that's been a lot of questions. Currently, because of the changes, the billing is done by a regular E/M visit, so you can use your usual codes. All return patients for any concerns are covered by the insurances. Any new patients that have any kind of COVID 19 symptoms are also covered. However, new patients for any visit may or may not be covered. And so temporarily, we were told that there might be some coverage, but it's unclear. And then we're going to have to decide as a department if we do see these patients and they do need further procedures, such as a nasal endoscopy or a laryngoscopy or a microscopy in the future, we want to bring that in. And for those, that will be billed as a procedure visit only. And if there are additional time spent, you can bill that for time. The alternative is to bill the video visits as a time visit only. But I just wanted to emphasize those points that we can go ahead and start thinking about what kinds of patients would be amendable to video visits, how we're going to do that, and to encourage us to use the equipment that we're going to be given, and that the turnaround is quite encouraging in terms of as little as 48 hours to get you the hardware so that we can then set up the software so you can do video visits. I hope that was helpful, and thank you for your time.
And next is our Vice Chair, Peter Wong, who oversees all of our surgical care and the use of block time. And Peter is going to talk about how we're adapting in terms of our surgical flow. Thank you, Peter.
Thanks, Rob. So I'm going to share a little bit just from the experience of the rhinology service, but I think a lot of these things that we've learned really apply to all of the services in otolaryngology. And over the last 2 weeks, we really had a reckoning that at the outset, we really underestimated the risk that we subject ourselves to as otolaryngologists in managing surgical patients. Zara Patel will be discussing specific data on that risk, but it's known from the Wuhan experience that the specialists most likely to be infected were otolaryngology and ophthalmology. And that's not too much of a surprise. But the index case that we learned about that really got our attention in Wuhan was an endoscopic pituitary case where 14 members of the surgical staff were infected from this single case. So that goes along with all of the data that Rob originally presented in terms of understanding that the highest viral load is in the nose. And it's problematic because this highest viral load is at the earliest stage of the disease when patients may not necessarily be symptomatic. So our contacts in Wuhan felt that for COVID positive patients, an N95 was not enough, and that all the providers in the operating room must have the powered air purifying respirators for adequate presentation. Really, in terms of cutting back on the surgical volume, we already discussed urgent versus emergent cases. And I think what I really would encourage us to think about is what really constitutes a true urgent or emergent case. The CMS guidelines have recently been laid out and distributed by email this afternoon to Academy members, but these are guidelines and not rules. And I think for ourselves in rhinology, our sense of what's urgent has really changed over the last week. So we started out saving all of our endoscopic skull-based cases, and then when we recognized that this was an issue with risk, we realized that these cases were not truly emergencies, and we were able to postpone almost all of them. So we do expect the cases that remain on the schedule to be reviewed by division chiefs, and we hope that you will be very judicious in your consideration of not only what's best for the patient, but what's best for the surgical staff as well in terms of protections. And in terms of that, what is proper preparation for the endoscopic sinus and skull-based cases? We are expecting, this is based on recommendations from the Wuhan surgeons, negative COVID testing ×2. And this has not been worked out formally yet, although there is an adult pathway that's being worked out right now, and we don't have a similar pathway yet for children. But this is their recommendation was based on the false negative rates that are known with current COVID testing. And there was a published paper that discussed this from China, talking about the fact that the viral load changes in a single negative test does not exclude COVID positivity. And they talked about the fact that a patient may be negative one day and positive the next. So again, that's in evolution. We've been very fortunate that Rob has been a really strong advocate for us to raise these concerns to administrative leadership. But this is a story in evolution that we'll probably have to share with you again in another few days. That's all I have, Rob.
Great. And now Zara Patel, who's a professor in our program and is a sinus surgeon with a special interest in endoscopic skull base. Zara is going to share some of the material that she discovered, the evidence around the risk of endonasal and particularly powered endoscopic nasal surgery.
Thanks, Rob. Hi, everybody. So basically, I don't have any slide to share, although I can share some graphs if you'd like. Rob already covered pretty well this fact that there is a high viral load in the nasal cavity. If you'd like, I'm just going to share my screen actually, and I'll just show you this while I'm talking about this part of it. So this is basically the image. If you look here, PCR detection of SARS-CoV-2, and you can see that compared to lower down in the airway, the throat swabs, nasal swabs are definitely higher, and the viral load was detected in asymptomatic patients similarly to symptomatic patients. So it doesn't really matter whether or not people are symptomatic or not. So let me just stop that, and you'll get me back. The fact that this, we don't know actually the amount of aerosolization that happens with each and every single procedure, but as Rob mentioned, when we're doing endoscopic surgery, there are drills used, there are powered instrumentation, we use saline irrigation. All of these things we know can aerosolize particles. So as Peter briefly mentioned, and I'll go into just a little bit more detail to give you all a little bit more information, we have a neurosurgical contact. Usually he works at a hospital in Shenzhen, but he was giving service at the Wuhan hospital at the height of the epidemic. And he is the one that reported this first case. It's now been reported in the media also through other sources that this one case caused 14 infections, and some of those were deaths. And he said he saw this repeated similarly in other endoscopic cases. And in his opinion, that means that endoscopic endonasal cases are actually some of the highest risk procedures that we could be doing right now. And it was through his experience in that hospital where this recommendation of N95s not actually seeming to be enough to stop that spread, only when they use PAPRs, the powered air purifying respirators, those big hoods that you see, only when people started using that did they see a stop in that spread. So I think that that is really important for us to keep in mind. Ed, I know that in that protocol that you showed, that algorithm, N95s are being used for high-risk cases. I do think that we need to keep in mind that in some particular situations, the risk may be even higher and PAPRs may be necessary. And I am well aware, as I'm sure everyone else on the call is, that the scarcity of those must be pretty high. And hopefully, all hospitals and administrations are trying to access more of that as much as they can as well, in addition to the N95s for everybody. The other information that I would share is, also anecdotal, but, Hamid Sajadi is on this call, and he shared with us some information. And I think Nilesh is probably going to touch on this later about the global effect, but certainly in Iran, ENTs seem to be affected at higher rates than perhaps the general physician population. We know that there are several in the hospital as well as several in isolation. Some young, otherwise seeming healthy ENT physicians have unfortunately died from this. And we think, the data that we're starting to look at appears to suggest, and this is just a theory right now, but because the viral load seems to be very high in the nasal cavity and nasopharynx, and we are very close to that airway, that may be why with higher viral loads, seemingly younger people that shouldn't be as affected are being affected in a greater capacity. From Italy, I have a contact in Italy who has shared other data about how this is affecting the ENT community there. They also seem to be greatly affected. He actually reported that loss of smell and taste is a huge thing that they're starting to notice, not just in patients, but also in the physician population. He actually himself noticed a loss of smell and taste as he was caring for these patients, and then started asking other ENTs in his area, who confirmed that they also were having this happen to them. He was going to send out a survey, and I actually tried to get more information from him about overall rates of illness or death in the ENT community there, but unfortunately he is actually currently now being tested because his own situation is deteriorating. So I think that all of these reports definitely, as Peter said, have been very sobering over the last just 2 days, really, that we've been getting a lot more information. And, we certainly don't want to overreact, but I think that it would be wise for us to listen to the cautionary advice that these people are giving us that have already been through this situation and have already lost their own colleagues. So I think that, an abundance of caution now will save us from repeating the same mistakes of other places. I think that probably is about all I have, Rob, unless people have questions.
Well, thank you very much, Zara. And, just today, they don't do asymptomatic testing now. Essentially, they're not. Even if, a loved one or you operated on a patient or you had an obvious exposure, unless you have symptoms, they haven't. But they've just allowed us to screen our preoperative endoscopic skull base cases 2 days before surgery. And we do think screening will become universal eventually for everyone who needs general anesthesia with intubation, and certainly for airway surgery. But right now it's rare numbers, just a handful of tests being allowed, but this area is recognized as such an exceptionally dangerous area. And I think the message is best not to undertake endonasal or endoscopic endonasal surgery unless absolutely necessary, and use very high level of precaution, and try to get a COVID screening before if you possibly can. So thank you very much, Zara. And with that, I'd like to introduce our Division Chief in Pediatrics, Alan Chang, who's going to share the insights from our Children's Hospital.
Hi, everyone. Let's see. I just have a few slides I'll try to keep this short. I know it's running late. Can you guys see this?
Yeah.
Okay, great. So this is very Stanford-centric. Apologize for many people who are from outside Stanford. So I think a lot of things have happened, and we're very fortunate to have a lot of input from our adult colleagues, just because there's not a lot of guidance and data out there for kids. But given what's been known, we have started this Monday to have really canceled all the non-urgent visits in clinic to really limit this to pediatric patients who have urgent needs. So we coordinated this with our pediatric audiology teams as well as other ancillary services. So the coordinated visits were canceled. It actually took some pushing for the to implement screening outside the clinic. I think part of the hesitation before was that if we have tactile fever and cough as a screening criteria, then most of the kids will be turned away or isolated. But so far, we did start out, we did push out the screening across sites, including 3 sites of ENT. And also because of some of the recommendations from our adult colleagues, including Peter and Zara, we have really limited our use of endoscopy in clinic to limited cases such as, stridor or post-op need to assess the airway. And as you can imagine, because of in kids, when we scope, we have to hold the child. We really try to limit the number of personnel in the room, again, using N95, face shield and gown. This is both from protection purpose as well as limiting PPE use. So I would touch on some of the direction we're taking to really convert our outpatient to telehealth. And similarly, I think in addition to sinus, a lot of the airway cases consoles, any exposure to mucosal surfaces, we really try to limit those non-urgent cases for the next 30 days. So I think what we call non-urgent is a moving target. I think we definitely taking a more cautious approach as a group. I think I'm speaking for every faculty, just because we know that many of our patients can be asymptomatic, but they can be major carriers. And we are definitely under testing as a group at this point. So we don't really know who might be carriers. So both in the ER, both in the OR as well as during the inpatient consultation, we really try to limit the endoscopic use, limit personnel, as well as full PPE usage. This also includes trach changes as well as other endoscopic procedures during consultation. So we have been pretty active this week. Just during this transition, we have conferred as much as we could in inpatient visits to virtual. I think all of our faculty have done online training, including all three of our APPs. So the go live date is going to be next Monday. We have actually enabled the exam rooms in all three clinic sites to have the necessary AV components. Some of the initial thoughts we had was obviously the simple ones, such as reviewing sleep studies, scans, and obviously some post-ops that might not need a in-depth physical examination, and obviously discussing some treatment options. We will see how this rolls out in the coming weeks, because many patients may not have MyChart activation. They need access to computer device. But we do want to include new patients. I think one message from our colleagues as well as our leadership is that we do want to keep the clinic staff engaged. We don't want them to, we don't want to cancel clinics altogether. So this is one way to have them stay engaged, as well as have opportunities for new patients who might otherwise need several weeks to wait to be seen. We can have them be seen, and then, like Jenny said earlier, have the necessary examination defer at a later date. And as Jenny mentioned earlier, I think Ed Danvers touched on this as well. There's going to be additional capability that allow telehealth for providers to work on their own computers from home. So there's many steps that can enable us to care for our patients in the coming weeks if this drags on. Another thing that our pediatric ENT colleagues have done around the country is Albert Park has kind of rolled out this survey across 30+ pediatric programs around the country. So we kind of have an idea of what each other program is doing and rolling out, including UCSF. I've been in touch with Michigan and Seattle, what they have done in their clinic. Difficulties you might encounter or they might encounter, we actually compare our notes. So this is another resource that is very useful, I think, for everyone, that you can see how other places are, meeting these challenges as well. So that's all I have. Thank you.
Thank you very much, Alan. I don't see any specific questions directed towards you right now. After that, I'd like to introduce John Sunwoo, who's the medical director of the entire service line in the Stanford Cancer Center, representing our division, and will share with us some thoughts about what cancer cases are urgent, for example, and have to go, and which ones can wait.
Thank you, Rob, and good evening, everyone. I'll try not to be redundant with what's already been presented, but I wanted to highlight a few things that are unique to cancer and the head and neck cancer head and neck CCP. What I'm going to talk about are prioritization of OR cases that our group has come up with. We've come up with a list of cases that we think are that should not be postponed, and ones that we think can be postponed greater than 30 to 60 days. I'll also talk about some PPE considerations for the OR for particular head and neck cases, and some considerations for the multidisciplinary care of cancer patients. So this was a discussion that was led by Chris Holsinger among our group of head and neck surgeons to decide which cases we should proceed and not reschedule. Overall, cancer cases, as Ed had mentioned earlier in the tier system, are considered tier 2. So they're considered within the urgent category, but as you know, not all cancer cases need to be done with the same amount of urgency as other cancer cases. For the ones that we've decided we should proceed and not reschedule, these include HPV negative head and neck squamous cell carcinoma, especially those with airway concerns, HPV positive head and neck squamous cell carcinoma with significant disease burden, or the ones that come in with a delay in diagnosis from the community, as well as cancer cases that or cancer patients that have complications from cancer treatment, surgery or otherwise, recurrent cases after chemoradiation failures, some thyroid cases, which include surgically resectable anaplastic thyroid carcinoma, medullary thyroid carcinoma, some papillary thyroid carcinomas with suspicion for or demonstrable metastases, large follicular lesions, recurrent lesions with active progression and a pace that we don't think could wait for a longer period of time. Parathyroidectomies with patients in renal function that's declining, skull-based cancers requiring surgery, salivary duct carcinoma or other salivary malignancies with a particularly aggressive histology, and some skin cancers, some melanoma and Merkel cell, as well as advanced stage non-melanoma skin cancers, and certain basal cell carcinomas in critical areas such as the orbit. The cases that we've decided could be postponed more than 30 days include low-risk papillary thyroid carcinoma without metastases, some melanoma cases. Cases that could be postponed for longer periods of time include benign histology or certain carcinomas with pretty indolent progression, as listed here. And then on a case-by-case basis, we'll decide for rare histology of uncertain rates of progression, certain diagnostic procedures that need to be done, as well as some benign cases. And we've actually decided to have a half-hour period before tumor board each week to discuss any cases that are kind of on the fence among the surgeons. Some PPE considerations in the operating room. So we talked about cases where as Zara had mentioned, there's certain cases that are at high risk for transmission of the virus. And we kind of categorize these into operations that include cutting the mucosa, such as anything in the oral cavity or oropharynx, as well as laryngeal operations and direct laryngoscopies, maxillectomies or rhinectomies. The low risk operations are ones we've decided that don't involve transection of the mucosa, such as thyroidectomies, neck dissections, parotidectomies, etc. And then some considerations for multidisciplinary care. So the way we do the way we see patients in the cancer center, here at Stanford, all the medical oncologists, radiation oncologists, and the head and neck surgeons see patients in the same clinic suite. And typically patients will often come in and see multiple providers from different services at the same time, because some of them are coming from long distances. This includes both new patients and patients undergoing tumor surveillance. Often the patients would typically get
scoped by multiple different providers. And we've decided to limit this and really curtail the number of endoscopic exams that are being done. We'll coordinate that among the care team. And we've also designated specific rooms where the scope exams will take place. In addition, we'll have a specific room for donning and doffing the PPE prior to doing endoscopic exams. So we've decided at the institution level, led by Rob, to wear full PPE, including N95 masks, as well as a face shield over the mask when doing a fiber optic exam. And so that we'll have a specific room for donning and doffing the PPE. For surveillance patients, we will really try to refrain from scoping unless there's some reason to, such as a new symptom or it's necessary for care or surveillance of that particular patient. And we'll coordinate that so that only one member of the care team does the scope exam. We'll try to videotape everything. We have specific rooms and equipment designated for that. In addition, as has been mentioned multiple times already, we've really implemented video visits, and we're trying to convert as many of the follow-up patients to video visits, and ones that we can't or where we really need to do a physical exam, we'll reschedule them to another date, as long as they're considered non-essential visits. And whether a visit is non-essential or not is really being left up to the care team and the provider. We're not coming up with specific criteria, except for perhaps tumor surveillance patients that are over 2 years out from treatment completion, unless there's some kind of active issue that's being followed. And then we've discussed to some extent whether or not patients who are receiving chemotherapy and are on treatment should come in for their pre-infusion visit by medical oncology. There's some discrepancy on this from the cutaneous oncology side. Some of the medical oncologists feel that they could do a video visit with the patient just being in the ITA, getting their labs drawn prior to infusion. Our head and neck medical oncologists feel that they would rather see the patient in person. So there's still some ongoing discussion about that. And finally, for tumor board, we've really culled the number of people in the room down to only the essential people presenting, and we've been implementing WebEx presentations by both the providers and presenting providers, as well as radiology and hopefully pathology soon. So just to give you an example of what we've done with video visits, this is just a count from the last week. And you can see that until just a few days ago, we were doing we weren't really doing any video visits. And then starting this past Monday is when we started converting a lot of the patient visits to video visits. Of course, the number of the encounters have gone down just because of rescheduling or postponement or patient preference. But we've really tried to ramp up as many video visits as possible for the patients we feel that don't need physical exams at that particular moment. So with that, I'll stop and go on to the next presenter.
Thank you very much, John. And now our next presenter is our Chief of the Palo Alto Veterans Administration Medical Center, Davood Serjani, who's going to give us just the highlights of how the Veterans Hospital has adapted. Well, we know the federal response has not been great to COVID, and it may be that we don't have Davood online, or Davood, you may be muted.
Load up I'll just summarize because it's getting late and I'm still at work. The VA in Palo Alto actually, nationally, our numbers for veterans that are COVID positive is far less than what is seen in the rest of the country. And I'm not sure if that's because the veterans aren't seeking care or their general social isolation is actually protective. But we have very few veterans that are critically ill in the country right now. And many have been tested. At the VA in Palo Alto, we are getting more, we're short in supply for everything, but luckily the federal government has allowed usage of expired N95 masks that will be coming. We are going through airway protocols with anesthesia. As an otolaryngologist, I feel like I need to be their backup. And the agreement we have with anesthesia is that when they have to intubate a COVID positive patient, they have to wear the level 4 gear, which includes the eye goggles as well as an N95 and the PAPR. And that gear takes about 20 minutes to get on. So it's very important that if they can't get the airway with intubation, that they need to be trained in flash trachs and call us afterwards to come and convert that. So I've actually been personally trained on dopping on and off, and I recommend everybody that's going to take part in this to do that, because it takes some training to get in a habit. And you should do it with a colleague of yours, because it's not just, you need someone else to help you get on and off the gown, and your partner's training is just as important. And some centers aren't allowing residents to go in the operating room for COVID positive patients. And so it's very important that you partner up with a colleague to treat these patients. And also it might be important to change your schedule so that your workforce is not always working at the same time, and you're taking shifts of 2 weeks on, 2 weeks off. That way, if one crew gets positive, they're not spreading the virus as an asymptomatic spreader to other patients or other colleagues. And so it's important to protect other patients as well as the workforce. That's pretty much, and the VA is doing some amazing things with industry. So in addition to working with government, we have an in-house test at the VA in Palo Alto for COVID-19. We work with Stanford, as well as certain companies that our suppliers are touching base with. In the next 2 weeks, the FDA is going to approve at least one company in the Bay Area that I know of that has very high capabilities to do about 1,500 tests a day. That's pretty much all I have.
Thank you very much, Dawood. I'll just mention that we've talked about the training of use of advanced PPE and the notion that you have two people each putting on gown and systems. We just don't have enough PPE to train everyone that way. It would be a big draw on the supply that's needed. So, learning perhaps somewhat virtually, there are lots of websites that will train it. Ultimately, when the inventory increases, we'll be able to do the optimal kind of training. So thank you very much, Dawood. Lori Lalakea is our chief at Santa Clara Valley Medical Center. And I think, Lori, you're very much in the thick of it there at Santa Clara down in San Jose.
Hi, Rob. Hi, everyone. Thanks for asking us to speak. So we have some unique challenges with our patient population, higher homeless population. We take care of custody patients, and those pose some challenges. Much of what we've done is similar to what has already been mentioned. So in our clinic, we have gone to urgent only, decreasing our volume probably by about 80 to 90%. We do not have right now the capability for video visits, but we have gone to telephone visits for a number of our patients, and that has been very well received. At a minimum, it has allowed us to have a screening interview with patients to understand whether the patient with hoarseness really needs to be seen and scoped in the next couple of weeks, or is something that has no danger signs and can be postponed. In terms of our clinic, we do pre-screen with phone calls the day before, but as we've discussed, patients may be asymptomatic carriers, and so that is only partially effective. We do have our building access controlled both to the clinics and to the main hospital with fewer entrances. We have a no visitor policy. all employees as well as patients have temperature screening as they enter the building. And for employees, they then get a sticker to put on their badge that is color-coded for the day of the week, so that it is obvious that you were screened and admitted correctly today. We also have really tried to limit our scope exams. We are using the N95 and face shield for that. We have gone to, rather than spraying local in the nose, we put local in on pledgets to reduce the aerosolization. And we have also, we're implementing a room closure after the scope exam to try to limit exposure to those aerosolized particles. So we close the exam room for 3 hours afterwards and then have a complete cleaning of all surfaces by our staff. For our telephone visits, we have now a very nice templated note that includes statements such as the visit was conducted as a telephone visit due to extenuating circumstance surrounding COVID. It documents, who the patient was or who the family member was, whether or not the visit included translation and who that translation was. And then we also document that 2 patient identifiers were used at the beginning of the visit. In our ORs, we've also gone to urgent cases only, again, with the idea that the patient could not be postponed for 30 days. Patients do receive a screening phone call the day prior to their surgery to rule out cough and fever. If there is cough and fever, there is an expedited fast track process to get those patients evaluated and tested and hopefully turned around and put back onto the schedule if they test negative within a 48 to 72 hour time frame. We have a new procedure now in transporting patients. Instead of going to holding area, if you are an inpatient or you are an ED patient, you are brought directly to the room just to avoid exposing those in the holding area to those patients. And we have special attention to trying not to bring patients in that are high risk, the usual criteria for age and comorbidities. We also consider whether patients are nursing home residents where they might carry virus back to the nursing home, or custody patients where they might carry virus back to a vulnerable custody population. In terms of hospital care, we've asked our residents to try to conduct virtual consultations as much as possible. If there is a need for a physical consultation with an inpatient, we've asked them to discuss that directly with attending staff so that we can jointly determine the need for that in-person evaluation. That is mainly it. One other thing to note is that Kim Shepard in our group chairs our hospital ethics committee and has been in the forefront of trying to pre-plan for social justice considerations in the setting of resource constraint. And that's all I have.
So thank you very much, Laura. I know you guys have a real challenge, and I think you're rising to it beautifully. I will say we have 4 more speakers in a very short amount of time. So what I'm going to do, Nilosh, I'm going to hang on for a minute, and I'm going to ask Tony Ritchie, because these are things that we really need to cover, is education, research, and administration, and we'll save Nilosh for last. Tony, can you give us a quick summary of the measures we're taking as a department in terms of our research community? Tony Ritchie is our chief of the Division of Research.
Hi, sure. So we really started planning a couple of weeks ago for remote working. And so right now we've transitioned probably 95% of the work is happening remotely. We've reduced our mouse lines and kind of put things into a holding pattern We've frozen down most of our cell lines for the same reason. So there's really not too much happening in the lab. We've shored up our IT so that people can log in and work from home. We've reassigned some people to jobs that are kind of more relevant to what we're doing now. So we have someone that's overseeing and ensuring that the computer systems are working, that's ensuring that we have licensing for all of the analysis software so people can do all of that. I think we've transitioned pretty well to Zooming lab meetings and Zooming some teaching opportunities and Zooming journal clubs and things like that. So on the work side, I think everyone is really kind of maximizing their efforts there. We've also have set up a system where there's basically backup plans of if people can't, if people get sick and someone else needs to check the mice or work on the computers. And if the people that are sick need care, because we have a lot of people that are either living alone or they're roommates with people they don't really know, and they've had a lot of anxiety over everything that's going on. And so kind of making it more of a community feel and realizing that, there's a lot of backup and things like that, I think has been helpful just to try to keep everybody a little more even keeled. So that's kind of where we're at. I think we're trying to build new projects. We're working on kind of longer term plans for funding and things like that as we start looking at how long this is going to go on. My assumption is for us, at least in my lab, I guess I'm telling people not to expect to really be back at work likely till June in terms of being able to do experiments at any regular level. I tend to be a worst case scenario person, but that seems, at least the models I've seen, that seems to be where we should expect it. And so we're working out projects that we can do in that time. It's really, I think things will grow as people kind of find some balance and some flexibility. We'll build some projects and some more interactions over the next couple of months that'll probably put us in a better place when we do get back to work, whenever that is.
Great. Just a little bit about security. Now that our research buildings are largely empty, we're augmenting the security patrols, and also it's only badge access to the buildings. And in fact, there are certain essential individuals that have to go for animal care or cell lines or critical experiments that might, if not be done, undo many years of work. And those individuals need a departmental letter to get past challenges from our security folks, which Tony's been kind enough to work through that process. And we have a list of critical research team members who need to go in to the laboratories.
Right. Yeah, so that's all been done. That's
all right. Thank you very much, Sean. So just to share that with our other colleagues at the other institutions. So thank you so much, Tony. Appreciate it. And on to Kwong, who's going to talk about impact in educational programs and the really good news of the consortium that's growing around the state. Yeah.
All right. I'll try to keep this brief. I don't have any slides to present, but obviously the changes have really affected the resident experience, both from experience in the operating room as well as in the clinics. As Dr. Jackler has mentioned before, we have scaled back obviously to urgent cases only, and then in terms of cases that can be done by a single operator, we have been having the attendings do those cases, so the residents aren't even going in the room. We're going to try to augment that by doing recordings, video recordings of the surgeries, and then potentially doing some simulation-based training if it can be done by the residents themselves without close interaction, without interaction with a faculty member. There was a question that came from one of our guests earlier in the evening that kind of touches on a lot of things that I wanted to talk about. So one question was, have the residents been scaled back to a skeleton crew? Well, because of the the decreased number of cases and residents not really being involved in the clinic as much, we have been able to decrease the resident load or the resident teams each day by one resident, and we're basically rotating one resident out, sending them home, or keeping them home a day at the Stanford rotations, and then the VA has been doing that as well. This is happening for a couple of reasons. I think one is obviously we're trying to protect our residents from exposure, trying to keep as few residents exposed as possible. And then, hopefully this will serve as a kind of reservoir of backup personnel in case somebody does become infected or at least put into quarantine. So that's the second question, is what contingency plans for coverage do we have in place? Well, first of all, as I mentioned, since we're keeping a resident at home each day, hopefully we will have less people that are in quarantine or infected, and we'll be able to replace the residents that way. In addition, we have one resident in full-time research and one in half-time research and one resident on elective. And so far we haven't had to tap into those residents yet, but it's come close a couple of times where we've had to pull, might have had to pull residents from the research rotation in to cover a clinical rotation. So that's the second thing. And then the third thing, question was, what alternative didactics remote learnings are being implemented? Well, first of all, this year we actually switched over to Zoom meetings for resident education for our remote sites, for our Santa Clara Valley residents as well as our VA residents. So that has kind of gotten our infrastructure in place to be able to convert resident education sessions to Zoom meetings entirely. So for our Monday morning case conference didactics, as well as our resident-led resident education sessions, we are doing virtual didactics via Zoom. What I've done is had the individual service teams Zoom in together. I felt that it was best to keep the resident teams segregated, but they are rounding together, so they're already within their own presence. So I thought at least we keep the teams together for the Zoom meetings. And they are interactive, and they are able to ask questions or comment on the lectures that are, or the didactics that are happening. So to further that though, we have actually had a discussion amongst the chairs and the program directors around this for the residency programs around the state. And for those of you who have not seen, you might expect to see an email from your chair or your program director that is announcing a new residency education collaborative online video instruction and discussion forum, which is cheekily a acronym for COVID. That was coined by John Ogilvie at USC. But we're going to initiate this next Monday, and it's going to be from 4 to 6 p.m. 2 hours each day. We'll have 2 separate lectures of about 45 minutes with 15 minutes of discussion. And what we're going to do is rotate amongst the faculty at all the different member institutions. There is a sign-up sheet for faculty that have been asked to participate, and we'll have daily lectures that hopefully, residents from all institutions can dial in through Zoom and be able to watch and participate. I think this is a great opportunity. We're going to be able to learn from some of the leaders in our field that you might not be able to see except for at meetings every, national meetings, et cetera. So that will be coming on. And then the last thing I'll say about this is I'm encouraging the individual teams to, if there's downtime, to do some case-based learning. So faculty, pulling up some cases to discuss with the residents during the day if there's free time and there's nothing else happening right now. That's all I have for us on the residency program side. I'll pass it back to you, Rob.
Well, yeah, thank you very much, Kwong, and I'm delighted that we're augmenting didactics across the state, and maybe this consortium that brings together all the different residency programs in the UC system together with USC and Stanford and Kaiser. It's a wonderful thing, and hopefully this will set a precedent, a silver lining that will come out of this crisis that we have today. With that, I'm going to ask Jason Irwin, then we'll have Nilosh. But Jason, I know we have a number of members of our administrative team, and those of us who live in academic departments, greatly value the core administration that supports us. Jason, have we got you here to say a few words about how we've adapted our administrative structure?
Yeah, I'm on. Can you hear me?
We can hear you.
Okay.
Go make your bed, will you?
What's that?
Make your bed. It's not.
Yeah, I probably should have cleaned up beforehand. Anyway, so we did make some adjustments to the schedules actually starting last week when we were looking at more of the social distancing. But then we actually had to make further adjustments once the shelter in place came about. And so now pretty much all the staff are working remotely. And everybody has completed a temporary telecommute agreement. So we have all those in place. All the staff are available they're using email, Slack, cell phone. If you call their desk phone, most of them have that forwarding to their other phones, so you can reach them in any of those ways. We did have a staff meeting this morning, our normally scheduled one. We did it over Zoom. And so we plan to check in with everybody regularly and also encourage the staff during that meeting just to interact with each other. And I know they're already connected via Slack, and they were talking about sending each other reminders to get up and move around and those kind of things. But I encourage you also to check in with your staff just to see how they're doing, not necessarily to give them more work, but just to ask them how they're doing. It can be, like Tony was saying, a little bit isolating depending on your situation. We have the copier and printer in the office at 801 and over at Edwards, where if you do need something that you have to scan it, most of them are programmed already with your email, so you could scan something to your admin if you needed to, but you can also just take a picture with your phone and send it to the staff that way if you need to get something to them. And all the staff do have a way of connecting to all of our systems, whether it's via a laptop or their home computer. And so everybody's trying to keep up with things, but please be understanding as they're working through this new norm of working from home. And myself, you can see I'm sitting in my bedroom. I had to set up a desk here in our bedroom, so I had a place to work. So, but yeah, I think all the staff are adapting very well, and we'll continue to check in with them. So if you have any questions or any issues, please contact me and let me know. But we're working through this the same as everybody else.
Great. Thank you so much, Jason. As you know, we value tremendously everything that you and our entire team does. None of the things we do in healthcare, education, and research would be possible without all of your partnership. And I want to thank Tanuja for helping technically set up today's telecom. Well, we saved the best for last. Nilosh. We're going to spend a few minutes talking about global perspective. Nilosh is one of our residents who really jumped right in. And I will admit, several of our residents have started writing already, putting together some of the knowledge about COVID. And Nilosh has taken a particular interest into the lessons from globally in OHNS.
Thanks, Dr. Jackler. I'll share some of the experience that we've heard from colleagues in affected countries, and I'll keep things brief because of the hour. As we've already heard from others, there was a very high rate of infection amongst otolaryngologists in China and Italy. In Iran, based off of reports that were sent to Dr. Sajadi by 3 senior otolaryngology faculty there, we've heard that 21 otolaryngologists have been hospitalized and at least 20 more are suspected to have the virus and are self-isolating. Most of these infections are thought to have happened early on in the disease course when PPE was not being utilized perhaps as stringently. And troublingly, we've also heard of at least 2 deaths amongst otolaryngologists in Iran, including 1 chief resident there. As Dr. Patel has mentioned, there have been reports of anosmia developing after infection and also reports of vertigo developing as well. I actually was in contact with an Italian otolaryngology resident today, and she was telling me that what Dr. Patel said, that there are similar reports of anosmia and dysgeusia there too. There are a couple of papers that have come out of the Wuhan experience in terms of risk mitigation for some of our most vulnerable examinations and procedures. For flexible laryngoscopy, as has been mentioned by some of the prior presenters, using a gel-type topical anesthetic rather than a spray can help reduce aerosol risk, and essentially reducing the amount of sneezing and coughing from the patient reduces aerosol. The second area that many otolaryngologists have been thinking about is whether we'll be asked to perform tracheostomies in these patients. Unfortunately, the prognosis has been quite poor once patients require ventilator support. At 1 tertiary care hospital in Wuhan, only about 6% of ventilated patients were still on the ventilator at 28 days, with the rest either recovering or passing away. The SARS experience may provide some data in this regard. There's a paper in the Laryngoscope published from the University of Hong Kong that provides a number of specific recommendations and was able to successfully do tracheostomies without any transmission to staff. In talking to one of our otolaryngology colleagues in Italy, she also had some interesting perspectives around their decision-making on tracheostomies. So she was mentioning to me that they've actually, because of the limitation on ICU beds, they've actually turned to, in some hospitals, doing tracheostomies earlier because it allows them to de-escalate patients faster, although it does pose a greater risk, of course, to the operating room staff by doing that procedure. In terms of their preferred methodology for doing a percutaneous versus surgical, it seems like that's been an institution-dependent decision, although they have been trying to do the tracheostomies in ICU rooms in order to minimize transmission exposure by transportation to an operating room. Very briefly, one last thing about non-invasive positive pressure ventilation. As has been mentioned at Stanford, we are trying to avoid that because of the risk of aerosolization. Apparently in Italy, they have this helmet type CPAP or BiPAP that is seen in that image there that they've been able to use. Not something that's readily available in the United States, but is another option potentially. Thanks, Dr. Jacqueline.
Thank you very much. That was very informative. I just want to thank everyone. You know, I thought this would take about 2 hours, and remarkably, it did almost exactly 2 hours. I know that we didn't cover the financial implications particularly. These are things that I would put on a back burner now. I wouldn't worry about them. We need to worry about our health and the health of our patients. Perhaps our retirement funds, for those of you who've been saving in your 401ks. I hope you had Netflix, Safeway, Amazon, and Clorox, because those are about the only stocks that are doing well. I will say, I would urge you all to think about adjusting to a new normal in your domestic life. Find ways of enjoying being close to your family and reading, and certainly for our trainees and our faculty working on grants and the likes. And you know, just to reassure, we will all be fine from this. As long as you take good care of yourself with good hand washing and PPE and you isolate yourself socially, you're not likely to get it. And even those of us who are older, the percentages are still good that we will go on in life. Whether this is in May or June, whether it's a bit later, we'll resume normal life and we'll all learn from this challenging experience that we're having. But this will pass. Don't let it get you depressed. Try to just adapt to a new normal, both professionally and at home, and try to find ways of enjoying your family, enjoying the profession that we've all trained for and are participating in. And we will emerge from this, I'm confident, and perhaps better and wiser for having suffered the experience. So for the 169 people who stayed all 2 hours, it says a lot about your commitment and your willingness to learn and listen about this. Of course, things change very rapidly. We can do another much shorter telecon for the entire department and perhaps for others in the coming weeks if we need to just update, as circumstances are very fluid. I thank you all and I bid you all good night. Thank you.